Annie Swanepoel once again. As a background to Annie, she's a consultant child and adolescent psychiatrist in the UM's LD service, but also has a PhD in human physiology and a special interest in neurodevelopment, developmental trauma, and evolutionary psychiatry. And certainly the last talk she gave us was very interesting, which is on the website. But today's talk is going to be surrounding children with learning disability and prevalence of ADHD, which I think, evidenced by the number of people who've asked to join today, has been something that people are really looking forward to hearing about. In terms of housekeeping, I think if everyone can mute during the talk, and I'm happy to take questions at the end. So over to you, Annie, and many thanks for coming to talk today.
Thank you very much for inviting me, Ben. I'm very pleased to be here to speak about a topic which is close to my heart. So today I'm going to cover the definitions of challenging behavior and ADHD. We're going to talk about the prevalence in children with intellectual disability, the diagnosis, the treatment, and then thinking about what it all means. So challenging behavior is of an intensity, frequency, or duration that it threatens the quality of life and or the physical safety of self or others, and is likely to lead to responses that are restrictive, aversive, or result in exclusion. And it's important to keep in mind that children are telling us something through their challenging behavior. It's less often now, but there are still some people who just see it as being naughty and who don't think about what the underlying causes and reasons might be. Now, ADHD, according to the ICD-11, has streamlined the diagnosis in a way. So it's still inattention, hyperactivity, and impulsivity. Inattention refers to significant difficulty in sustaining attention to tasks that do not provide a high level of stimulation. So children who can play computer games who can play computer games for hours, that doesn't mean that they don't have inattention, because computer games are highly stimulating and they give you frequent rewards. So children also are distractible and they have problems with organization. That all falls under the inattention bit. Hyperactivity refers to excessive motor activity and difficulties with remaining still, most evident in structured situations that require behavioral self-control, so like a school. But in children that are severely disabled, even when seated in a wheelchair. I recently saw a 17-year-old boy who was so hyperactive sitting in his wheelchair that his father had to hold the wheelchair down because he was shaking and hopping, and he has already broken 4 wheelchairs. So that is a very clear indicator of hyperactivity. Impulsivity is the tendency to act in response to immediate stimuli without deliberation or consideration of the risks and consequences. So that is the people not having a gap between having a thought and acting. So immediately acting on what you're thinking, which I'm sure all of us can appreciate is a real problem because you don't have that control. Then just to continue with the diagnostic criteria, these inattention, impulsivity, and hyperactivity needs to be persistent, so at least 6 months, but usually much longer, with onset in childhood. The degree is outside the limits of normal variation expected for age and level of intellectual functioning, which as pediatricians, most of you certainly know all about. It significantly interferes with academic, occupational, or social functioning, which is an important point because some people can have ADHD without it impacting their functioning, and then they would not get a diagnosis. So it's only when it really impacts that you would give a diagnosis. And in order for a diagnosis of disorder, the behavior pattern must be clearly observable in more than one setting. So a child who has ADHD symptoms only at school, but not at home, may not have ADHD. It might just be that the school isn't right for that child. So, for example, children with mild intellectual disability who are in a mainstream school and are just not understanding the work may seem to be very inattentive and can become hyperactive. But if they are then in a setting where the work is pitched at a level which they can understand, they are able to concentrate and they settle down. So that is why you've got that criteria that there needs to be more than one setting. Equally, children who are fine at school but very hyperactive at home, you would want to know what's going on at home. Is it that they are very bored? Is it that there's nothing really for them to do? Are they anxious? So that's why you need feedback from home and school as far as children are concerned. But now there's something which is really important and which impacts on our thinking still today. And that is that ADHD in autistic patients and those with intellectual disability is not appropriately treated. We'll talk about that more. And this is partly due to the fact that ADHD was excluded in autism diagnosis in ICD-10. So that means that if a child was diagnosed with autism, it meant they couldn't be diagnosed with ADHD as well. And that has now been changed in the DSM-5 and ICD-11, but it's still a common misconception I come across in both parents and professionals where they'll say the child is autistic, therefore they can't have ADHD. And that is very unfortunate that that was the case in the previous diagnostic manuals, but that has been rectified. So, does ADHD occur in people with intellectual disability? Yes, it does. And not just at the same level, it is at least an 8-fold higher prevalence. So I just want to pause there for a brief moment. Can you just imagine it's at an 8-fold higher prevalence in children with intellectual disability compared to neurotypical children? So this means that children with mild intellectual disability, 50% of them have ADHD. And this is even if their mental age has been taken into account. So if you think about your caseloads of children with mild intellectual disability, do 50% of them have a diagnosis of ADHD? Or 50% of them being treated? And if not, it's a real problem because we also need to keep in mind that as clinicians, we are seeing the children with problems. So the ones who don't have ADHD may not present to us at all. So the chances are that in our caseload, the percentage is even higher. And the 50% was in mild ID, and we know that the greater the level of intellectual disability, so with moderate, severe, and profound, the higher the prevalence is. The other thing that we know is that people with intellectual disability have more severe symptoms of ADHD, and they have a lower tendency to improve over time. So you know how some children can outgrow the hyperactivity. Neurotypical children, that's less likely to happen in those who have intellectual disability. So ADHD in children with learning difficulty is a real problem because there is a risk that their symptoms of hyperactivity and inattentive behavior is attributed to the learning disability, and this is called diagnostic overshadowing. So rather than seeing it as a coexisting problem, that this child with a learning disability also has ADHD, it's seen as, well, it's due to the intellectual disability that the child is hyperactive, inattentive, and impulsive. And it's a well-known fact that ADHD is underdiagnosed in both children and adults with learning disability, which is a real pity because children with learning disability already struggle to learn. And if they have ADHD, in addition to that, they are doubly vulnerable because they experience both the deficits imposed by ADHD and those associated with learning disability. And then ADHD, of course, contributes to challenging behavior because children who are very hyperactive, impulsive, not listening, tend to be a lot more challenging than those children who are not like that. And the other really important reason why we need to diagnose it is because ADHD is potentially treatable. Now, the college brought out a very important report. So this is the Psychiatry College in February 2021 about ADHD in adults with intellectual disability. And they said that an early consideration of ADHD in adults with intellectual disability is extremely important to improve outcomes, because ADHD symptoms may limit the ability of a person with learning disability to achieve their potential by causing significant functional impairment, as it may often present as challenging behavior. So the Royal College of Psychiatrists has a faculty of learning disability, and they have brought this college report out, which has gone to every learning disability consultant psychiatrist, and that is about think ADHD. So if you have an adult with learning disability presenting with challenging behavior, don't just use antipsychotic medication, think ADHD, because so many have been missed in childhood, not just due to clinicians, but due to the classification system, which didn't allow it, because so many have autism as well. So now that we know what to look out for and we know that it's highly prevalent, how do we make the diagnosis? Getting feedback. So we need to keep in mind that parents may not have experience of other children and may wrongly consider the hyperactivity, impulsivity, and inattention to be due to the intellectual disability and autism. So parents may be telling us that the child is normal, especially if they've had ADHD in their own family, and not realize that this is actually over and above what would be considered to be normal in neurotypical children. Furthermore, if we think about children with intellectual disability, in the UK, teachers at specialist schools for children with ID are not required to have any specialist training in terms of intellectual disability, autism, or ADHD. And this is worth emphasizing, because that means that if you ask a teacher about particular symptoms, they may not know, they have not had any particular training in that. And what they can do, though, is to compare the child with other children in the class. And they can tell you whether this child is similar to others or is more hyperactive than the others are. But, and this is really important again, be aware that if there's a high prevalence of untreated ADHD, the result may not be accurate, as the teacher may also wrongly consider ADHD symptoms as normal in children with intellectual disability. The other thing to keep in mind, of course, is that in specialist schools, there's a high ratio of adults to children, so that children will often have a teaching assistant sitting next to them and bringing their attention to task again and again and again, and therefore also think that this is something they need to do in any case, and not realize that this child has more problems with attention than they should. So what do we need to look out for? ADHD should be diagnosed when the child's impairment of attention and activity control is out of proportion to their developmental level, and it impairs educational, social, or family functioning. Okay, so we need to look for patterns of inattention, so needing to be brought back to task again and again, the inability to concentrate for longer than a few seconds or minutes, even on things that they're interested in. Like that boy I told you about, whom I recently saw, who had already broken 4 wheelchairs. I saw him getting bored, his father taking out the phone and showing him a video of Mr. Tumble, the boy looking at the phone, laughing, looking at it for perhaps 10 seconds, and then turning away and forgetting all about it. So even things that are interesting for them don't hold their attention. They also have increased activity, they have difficulties waiting, and we know that this should be pervasive across situations and persistent across time. Now, there is a really useful questionnaire, the TAQ. It's called the Activity Questionnaire. And it's something which can be used in children with intellectual disability, also if they are nonverbal, also if they are wheelchair users. And it was developed by Burbridge in 2010. So it's a list of 18 items, and each item has a response format. So where the parent needs to score from a scale from never, almost never, to almost all the time or always. And then it's all added up. And if we look at some of these, it's, does the child wriggle or squirm about when seated or lying? Do they fidget, play with their hands or feet? Do they find it difficult holding still? Is it difficult to remain still in their seat even when expected? Do they prefer to be moving around, frustrated if left in one position? When involved in a leisure activity, do they make a lot of noise? Are they boisterous? Do they act as if driven by a motor? Need very little rest? Talk excessively? Behavior seem difficult to manage whilst out and about? So many parents need a harness for the child, that you need to keep an eye on them all the time, do things without stopping to think. So blurt out answers, you'll see some of those are very similar to the Connors questionnaires. Respond to instructions before they've been given, want things immediately. So that's a typical one, cannot wait. Very, very difficult for parents to manage because the child, if they want something, they want it now. And disturbing others, difficulty waiting for things. So these are the type of things that we're looking out for in children with intellectual disability. So if parents answer almost all of the time, always, to these questions, you can be pretty sure that they will meet the criteria. And this is also something which teachers at school can fill in. So in adults, there was a recent study where they have concluded, this is adults with intellectual disability, that clinical opinion remains the gold standard in diagnosing ADHD. This is also true for pediatrics. So that questionnaire I told you about is helpful, but it's not necessary, and it doesn't exclude a diagnosis of ADHD if the criteria aren't met. So it's still the doctor specialized in ADHD who gets to decide. So if we have now diagnosed a child with ADHD, how do we treat them? And there's helpful prescribing guidelines for people with intellectual disability. And just to remind you again, the rate of ADHD increases with the severity of the learning disability. So in mild, 50% have it, and in severe learning disability, it's more than 50%. So if you have a child in your clinic with a severe learning disability, you almost need to find proof that they don't have ADHD rather than that they do, because chances are statistically that they have ADHD. And then just to make it very clear, and I'll talk about that a bit more, dopamine antagonists, so antipsychotics, are not recommended for the treatment of ADHD. It is not a recognized treatment, and I'll explain why. So first of all, we all know that prescribing for ADHD, the first line is stimulant medication. So if we think about methylphenidate, what methylphenidate does is it increases the noradrenaline and dopamine in the synaptic cleft. And this is worth keeping hold of because that's the action we want. So we know that children with ADHD actually have an understimulation of the brain. So they have an uncomfortable sense of feeling bored because of this understimulation. And that is why they keep moving around and keep looking for different things, because that then creates stimulation for them in order not to be in this understimulated bored state. And methylphenidate helps because it increases noradrenaline and dopamine, and therefore people don't have that understimulated brain state. But we know that stimulant medication is less effective and more likely to result in side effects in children with intellectual disability. So in neurotypical children, about 70% improve. In children with intellectual disability, it's about 50%. But the higher the level of disability, the lower the response to stimulants. So what I do is I start with the lowest dose possible, so 5 milligrams. And if there's increased aggression, I stop the medication straight away. If there are no negative effects, the dose can then be increased slowly. So it's really start very low and go slow. Be very aware of rebound hyperactivity resulting in challenging behavior when the medication wears off. So several children I've seen have been on Equisim, which then keeps them fine during school hours, but when they come home, they are then totally out of control. And that is due to the rebound hyperactivity, which can be more expressed more clearly in children with intellectual disability. So as I've said, 50% of children can improve with stimulants, but the higher the degree of learning disability, the less likely there's an improvement. And interestingly, there are genetic explanations, which hopefully in future we'd be able to diagnose, but at the moment we just need to try, and a careful dosage titration is recommended. So you might ask, what about comorbid epilepsy? So again, some years ago, they used to say in a child with epilepsy, you can't use stimulants. But nowadays, the neurologists aren't saying that anymore. And I've given you a reference there for children with epilepsy who've used methylphenidate. 18% had significant side effects, but none had an increase in seizures due to methylphenidate. So it's not an immediate no-no. Now, non-stimulant medication. This is often a better option for children with intellectual disability because they need 24-hour control of their symptoms to reduce challenging behaviors. Many of the children struggle very much in the morning. So their parents need to help them get ready for school. They need to go on school transport. And if they only have their methylphenidate just before they go to school in order to last them the whole day, that early morning can be so difficult. And again, as I said, you can have the rebound hyperactivity when it wears off. So that means that the parents can then really struggle early morning and evening. So here again, I start low and I go slow when using non-stimulants. I'll talk about those in a bit more detail, but I usually start with about a quarter of the recommended dosing regime for neurotypical children, and then increase in due course. But it's because it's better to err on the side of caution. So atomoxetine, we know it's a noradrenaline reuptake inhibitor, and it's very good also in children with comorbid depression because it's related to reboxetine, which is an antidepressant, and anxiety disorders. So it can help in those children who have other problems with depression as well. So as you know, atomoxetine needs a longer dosing period, and it may cause initial fatigue, headache, gastrointestinal symptoms, and should initially be started in the evening. Now, keep in mind that about 15% of the patients may react with increased aggression, requiring discontinuation of atomoxetine and switching to guanfacine. Interestingly, guanfacine seems to work better in children with intellectual disability than in neurotypical children. And this is something which I have also observed. So I wasn't that impressed with guanfacine in neurotypical children, but I am very impressed with it in children with severe learning disability. We know it's an alpha 2A agonist, So it also increases the noradrenaline effect. What's very good about guanfacine as well is that it's also reduces anxiety, and it's good for children who have tics, but it only comes in tablet form. And initially I let that put me off, but not anymore. What I'm doing now is I'm telling parents to teach their children to swallow tablets because it's such an important skill, and it will really limit the child's future as an adult who might need all sorts of different tablets if they can't swallow tablets. So it's a very important skill to learn. The way we teach parents to teach their children, and some schools actually have put care plans in place, is you recommend that a trusted adult demonstrates once a day, just once a day, by putting a small sweet like a Tic Tac on the tip of their tongue, and then take a sip through a straw from a glass and swallows. The adult then opens their mouth and shows that it's empty. So I'm explaining it for children who are nonverbal, so who need to watch and learn. The child then tries, and it's really important that there's no pressure and that this is treated as a game. So if the child bites the sweet or keeps it in their mouth or spits it out, the adult just says, no problem, we'll try again tomorrow. And the reason for sipping through a straw from a glass is to enable the correct head position. So you want the kind of chin to chest position, and it also avoids triggering the gag reflex. So this is what we tell parents to help their children to swallow tablets. But if they aren't able to swallow tablets and you need a non-stimulant, you can consider atomoxetine, which comes in liquid form. And of course, you know that in terms of stimulants, Alvance and Equisim can be opened. But if the child can swallow tablets, a low dose of guanfacine can be particularly helpful if the child is also anxious and hypervigilant, as it blocks the fight or flight response. And clonidine is an option if a liquid formulation is needed, because clonidine and guanfacine work in a very similar way. And interestingly, in neurotypical children with PTSD, so with post-traumatic stress disorder, guanfacine and clonidine are listed as treatments because it blocks the fight or flight response. So for those children who've had past trauma, like most of the very complex children have had in terms of hospitalizations and procedures, this can also be really helpful for them. So we know that the treatment of ADHD is under-researched in children with intellectual disability, and the evidence to support treatment is very limited. So there is a greater reliance on the therapeutic trial. What is known is that stimulants are less likely to work than in neurotypical children, and the more severe the intellectual disability, the greater the chance of an agitating effect. So this does not mean that the child does not have ADHD. And I've come across that more than once, where I've had children referred where they've said stimulants didn't work and therefore we've taken the diagnosis away. So this is not correct. We know that children have ADHD, but that they have a kind of a paradoxical response to stimulants and become more agitated if they have intellectual disability. So what it means is that we need to consider non-stimulant medication. So you might ask, what about antipsychotics? So antipsychotics work by reducing dopamine. It blocks the dopamine receptor and reduces the dopamine effect going downstream. And dopamine, if you remember, is the neurotransmitter which is related to enjoyment, to reward. So it's not a neurotransmitter you want to be reduced. Antipsychotics block dopamine and serotonin transmission in the midbrain. So this affects pleasure and joy, and people treated with antipsychotics may become and appear quite flat. So much so that it's been called a chemical straitjacket. So antipsychotic medication can reduce hyperactivity and impulsivity, but and this is very important, it does not improve concentration, and it does not enable children to learn any strategies. So what it basically does is it takes this child who's very hyperactive and impulsive and not concentrating, and it's like a chemical straitjacket just weighing the child down so that they sit still, but they can't concentrate, they can't learn, they can't take any strategies on board, and they are then condemned to a lifetime of antipsychotics, because the moment you try to take the antipsychotics away, they become more hyperactive, more impulsive, and then people say, no, this child clearly needs the antipsychotics. And this is a significant problem because we know that antipsychotics have got serious side effects and need 6-monthly blood tests, which again can be very traumatic for this population. So they are associated with weight gain, with hypertriglyceridemia, diabetes, mellitus, hypertension, and all of these can contribute to children then, even if we don't see these effects in childhood, if they stay on antipsychotic medication in adulthood, it can really contribute to being increasingly unwell. And I always think of the Hippocratic Oath. So first, we must do no harm. And I'm very worried about children with learning disability being prescribed antipsychotic medication unnecessarily. And I'm not the only one. So the Learning Disability Deaths Review, the LEADER review, has shown that 63% of people with a learning disability die before they reach the age of 65, compared to only 15% in the general population. So that's a massive difference. And the proportion of preventable, treatable, and overall avoidable medical causes of death of children with learning disabilities was 36%. And in adults, it was even higher. In adults, it was about 45%. So, and a recent study in the UK showed that of 445 adult participants, 65% were prescribed ADHD medication. This is now adults with learning disability. And those on ADHD medication were far less likely to be prescribed antipsychotics. So if we diagnose and treat ADHD effectively, it means that these children, when they grow up to be adults, will be far less likely to be prescribed antipsychotics, which will then mean that they're far less likely to have those side effects of on hypertension, diabetes, and that should improve their quality of life and their lifespan. So it is really important to remember that most children with intellectual disability are happy and content, and that intellectual disability on its own does not cause challenging behavior. Now, this might be difficult to believe because all the children we see do have challenging behavior, but we see only those who present to us. So we see only those with challenging behavior. All the ones who are happy and content don't present with challenging behavior. So when a child presents with behavior that challenges, it's really important to seek the underlying causes and to treat those. And I want to make it clear that challenging behavior is complex. So there are multiple different reasons why a child might present with challenging behavior. And in psychiatry, we use the biopsychosocial model where we use this table thinking about biological, psychological, and social determinants. And we think about things which could predispose, precipitate, and perpetuate, and also protective factors. And ADHD is just one little thing. So if we say this child has ADHD and that contributes to the challenging behavior, we are not saying it's just ADHD. There might be all sorts of other things going on. The child might be in an unsuitable school. They might have constipation. They might be in cramped housing. Their parent might be totally burnt out. So it doesn't mean that ADHD is the only explanation. But what I am saying is that ADHD is one of the really important ones. So when a child presents with challenging behavior, there are additive effects. So it's both this and that. It's not either or. And a common misconception is that ADHD cannot be diagnosed where there are attachment problems or developmental trauma. And this is not true because the two are not mutually exclusive. So having ADHD does not protect you from developmental trauma. Vice versa, if you have been abused, that doesn't mean you can't have underlying ADHD. To the contrary, it is known that children with ADHD are more likely to be abused. So it's more likely that you get both. And even if you cannot solve all the problems, which as doctors we can't do because we don't have direct influence over housing, over so many things that families struggle with, but we can diagnose and treat ADHD. And we shouldn't give up if we're presented with a really complex child and say that there's nothing we can do. We need to really think about the things we can do. And that is because ADHD symptoms can be treated. And as I've said previously, learning is already difficult for children with intellectual disability. And if they have untreated ADHD in addition, this can lead to a double hit on their ability to benefit from any psychological intervention which requires the child to concentrate for longer than a few seconds or minutes. Because we want these children to be able to learn to use PECS cards. We want them to be able to learn to sign. We want them to be able to communicate. And if they can't concentrate, they can't take anything on board. And that then means that our strategies for positive behavior support are very limited. So NHS England has launched STOMP, so that's stopping the over-medication of patients, and then also STAMP, supporting treatment and appropriate medication in pediatrics in order to address the overprescription of particularly psychotropic medications like antipsychotics. And your college has signed the following pledge. We pledge to ensure that children and young people with a learning disability, autism or both, are able to access appropriate medication in line with NICE guidance, but are not prescribed inappropriate psychotropic medication. And with the idea that people only receive medication that effectively improves their lives, so that people are not prescribed medication which has side effects but doesn't improve their lives. And this is also relevant for our service. So I work in a service for children with severe learning disability. And I did an audit when I started last year in February and found that 25% of the psychiatric caseload had a diagnosis of ADHD and were treated for it. But a further 25% of my psychiatric caseload had a diagnosis of ADHD but were not on medication for it. And half of those were treated with an antipsychotic medication due to challenging behavior. So I am trying very hard to change that. And I would be really grateful for your help because, as we know, untreated ADHD is a common cause of challenging behavior. And by providing a diagnosis and treatment, difficult behaviors will improve and the risk of the prescription of inappropriate antipsychotic medication will be reduced. Thank you very much.